Good evening, everyone. This is Rebecca Sharuk from the Office of Alumni Relations here at Jefferson. Thank you all so much for signing in with us this evening. For those of you in the New Jersey, Pennsylvania area, hopefully your power and everything is okay after this big rainstorm. So let's get started. Just some notes, some little housekeeping for this evening. If you are joining us by telephone, just make sure to mute your phones. And then also, please feel free to submit the questions throughout the presentation by using the question box. The question and answer session will happen after the presentation. Thank you. So we have a lot of alumni here tonight, and I'd like to introduce also Louisa Kopp, also from the Office of Alumni Relations, to give you a little background about who's joining us this evening and also what's coming up for our office. Louisa?
Sure. As you can see, we had more than 270 alumni from Center City and East Falls campuses participating tonight, and that's representing all of our colleges, 24 states, and even Canada. Our speaker tonight is Dr. Karl Doghramji. He's a Jefferson Medical College graduate, where he's our professor of psychiatry, neurology, and medicine at the Sidney Kimmel Medical College, and he's also medical director of the Jefferson Sleep Disorders Center. He's an active member of many professional organizations, and he has held numerous committee positions with the American Academy of Sleep Medicine. He's also authored more than 150 journal publications and book chapters, and has edited and written 4 books. His published works and research focus on a wide variety of sleep disorders. We have lots of exciting alumni events coming up this summer. Here's a list of a bunch of them. If you would like to learn more about any of our events or register to attend, please visit our website. And we're in the midst of planning for our events this fall, and we'd love to hear your ideas. So please get in touch with us if you have an idea for an event, or if you would like to volunteer to speak. We're always looking for speakers.
Great, thanks, Louisa. And I'm going to give the controls over now to our wonderful speaker. And just let me make sure that everything works for you, Dr. Doghramji. But let's see here. Let me just change the. All right. And there you go.
There we go. Thank you so much, Louisa. Thank you, Rebecca. Well,
thank you.
Thank you.
Can you hear? Can you hear me? Okay.
We can hear you.
Fantastic. Well, it's great to be here with all of you this evening. And as we just heard, there are a number of rainstorms going on, electrical storms. So hopefully, our electrical power situation will keep intact until the end of the presentation. It's great to be here with all of you. Now let me figure out how to advance. Oops, Daisy, that was not the right one. How do I go forward? Let me just check on this.
Just your arrow key on the computer should work.
Gotcha.
Forward.
It's not working, so I'm wondering if I'm doing something wrong.
Let's see.
Well, maybe I can just ask you to advance the slide. Would that be okay? Right, let's do it that way. Okay, so there is a very rich and prominent legacy of sleep medicine at Jefferson. I'm not sure if any of you realize this, but Eugene Azarinsky, who was the discoverer of REM sleep, that very important stage of sleep on which much of research in sleep medicine was established, was a professor of physiology right here at Jefferson many years ago. Albert Beale was a professor in psychiatry and wrote a number of seminal publications on dreams and dreaming. In fact, in his honor, we now have a number of annual lectureships which I organize and share within Jefferson. And the Jefferson Sleep Laboratory was actually the very first sleep laboratory to be established in the Philadelphia area to study sleep in 1978. Next slide, please. That is myself. That is I. And I came on board. I'm a Jefferson grad. I came on board after my training here at Jefferson in 1984. And I think that our contribution to sleep medicine at Jefferson and at Sydney Kimmel Medical College has really shaped in many ways contributed to and shaped the practice and clinical care of sleep medicine in the Philadelphia area, and we're very, very proud of that. Next slide, please. We have in our clinical practice at Jefferson Center City a state-of-the-art laboratory, a wonderful clinical facility, and we're very grateful to Jefferson that they've given us the opportunity to practice sleep medicine in this wonderful facility. Next slide, please. Our clinics also extend to the New Jersey area, southern New Jersey, and the Navy Yard in southern Philadelphia, with plans, of course, to expand additionally as Jefferson affiliates with and establishes footholds in wider geographic areas within the Philadelphia area. Next slide, please. These are the practitioners and physicians with whom I work at Jefferson Center City. I'm very grateful to the wonderful work that they do in sleep medicine in Philadelphia. We have a multidisciplinary center comprised of multiple specialties: psychiatry, neurology, medicine, pulmonary medicine, otolaryngology, all working collaboratively together. And I think this typifies the type of interdisciplinary collaborative work that many of us do at Jefferson in many other programs. Next slide, please. Now let's go on to sleep. As many of you know, sleep is an integral drive. It's like hunger, like thirst. It's a drive which exists and manifests itself if we deprive ourselves of the opportunity to sleep. Next slide, please. Sleep occurs in a forceful fashion in very awkward situations sometimes if people don't allow themselves the opportunity to sleep. Next slide, please. We see this also in the animal kingdom. This is the unihemispheric dolphin. I'm sorry, this is the dolphin rather. And the dolphin has a need to move and to be active and cannot afford to sleep and be immobile for long periods of time. Because of this, the dolphin has an interesting and unique adaptive mechanism where the one hemisphere of the dolphin actually sleeps, while the other one is active and engaging in wakefulness behavior and wakefulness physiologic functions. And then there's a switch from one hemisphere to the next, while the waking hemisphere now sleeps and takes advantage of the sleep process, while the other hemisphere sort of goes to work. Again, emphasizing the point that sleep is such an important and integral function throughout living species. Next slide, please. The true function of sleep is not well known, but research has been indicating to us that at least one of the important functions of sleep might be the clearance of poisons, metabolic poisons of the neuronal process. In this case, beta amyloid. There's an increased egress or excretion of beta amyloid from the brain during sleep than during wakefulness, and this egress begins to dwindle during wakefulness. Now, why this happens, why this function is unique to sleep or happens more during sleep is yet something which we have to understand. But clearly, the lack of sleep may have significantly detrimental function on very basic brain processes, and therefore we need sleep to be able to keep intact. Next slide, please. Now, many of you know that sleep is divided into various stages, which we define electrophysiologically. These are human sleep stages. On the very top portions of the slide, you'll see wakefulness, which has a rapid electroencephalogram of something along the lines of 8 to 12 cycles per second. But as we sleep, stage 1, 2, and so on, the EEG begins to slow down. And finally, during what's called here delta sleep, now we call this slow wave sleep or N3 sleep, the electroencephalogram is at its slowest, and the brain waves are at their maximum in terms of amplitude. In many ways, this delta or slow wave sleep is thought to be a more restorative or refreshing or deeper form of sleep, which we seem to need a lot of to be able to maintain the restorative or daytime, the rejuvenative aspects of sleep. Next slide, please. These various sleep stages, including REM sleep, which is here in red, are organized in a very distinct fashion in human beings, something we call sleep architecture. So as you can see on the left-hand side of the slide, there's an entry once we go into sleep, into stage 1, and then an orderly progression from 1 to 2, and finally to slow wave or delta sleep as we sleep. And as the hours of sleep increase, we finally emerge into our first REM period. This is in red on this slide. And that lasts for about 20 minutes or so. And then that cycle, which lasts about 90 minutes, repeats itself every 90 minutes or so until the very final REM period, which is in this case, of course, about half an hour or so. So REM periods increase in length as the night progresses, and slow wave sleep or delta sleep, this is the bottom portion of this slide, seems to occur primarily in the first half of the night. The point of this slide is that sleep is not a nondescript, undefined process, but there is a very orderly progression of sleep stages, implying a systematic control of physiologic and neurophysiologic processes by the brain. And it is the alteration of this pattern and of these processes that in many ways define sleep disorders, which we'll get into in a couple of minutes. Next slide, please. Now, these various sleep stages change in a relative proportion as we age. And there are many, many other factors also which change the relative distribution of these sleep stages, which I won't get into right now. Things like the menstrual periods, temperature, external influences like noise and so on. But let's just talk about age for a second. You'll notice that the red portion on the bottom, which is non-REM slow wave sleep, diminishes as we get older. It's very common for older people above the age of 60 or 70, to have very little slow wave sleep, which we think may be one of the reasons why the elderly may wake up feeling unrefreshed during the course of the day and have a need to resort to napping. On the other hand, as we age, you can also see that the yellow portion of the slide, which represents awakening, increases, and the light blue portion, I apologize, the dark blue portion, which represents stage 1, the more shallow form of sleep, also increases in contribution. So as we age, sleep becomes, the depth of sleep diminishes. We have more, the greater contribution of shallow sleep and even wakefulness. So in essence, we spend a bit more time in bed, but our sleep becomes less restorative, less efficient, and less productive. Next slide, please. Now, there are many, many disorders that cause alterations in sleep and cause some of the complaints that we see, such as insomnia and daytime sleepiness. So I'll be going over some of these in the next few slides. Next slide, please. Before I do that, however, I'd like to go over some of the sleep practices which we may, in fact, engage in, which may actually make sleep worse for us. And in the corollary of that statement is that there are many things that we can do to improve our sleep and to make ourselves sleep better in a non-medical situation, non-medical setting. There are so many things that disrupt sleep that are altering our behaviors alone could be very, very sleep productive. So I'll be going over this in the next 5 or 10 minutes, then reviewing some of the sleep disorders and how we handle them, and then I'll open things up for discussion. Next slide, please. So one of the things that is important to do is to allow adequate time for sleep. We all know this. The opportunity for sleep has to be there for us to be able to express sleep and keep our wakefulness intact during the course of the day. Now, next slide, please. The question becomes, what is an adequate time for sleep? The American Academy of Sleep Medicine developed this sort of normative set of hours based upon various ages. And as you can see on the very left-hand side, newborns have a need for roughly 14 or 17 hours of sleep per day. They spend most of the day sleeping and taking brief naps. As we age, toddlers, preschoolers, school-age children still have a fairly long sleep need. You can see the school-age children, 6 to 13 years of age, need between 9 and 11 hours of sleep. Young adults, 7 to 9 hours of sleep. And it's very common for us in society to violate these needs, this need for sleep, and therefore many of us tend to become sleepy as we age because of the fact that we're depriving ourselves of sleep. Next slide, please. The question becomes, what is an adequate amount of sleep? Well, one obvious way to assess that is if you're falling asleep in control during the day, as this woman is falling asleep, well, clearly you may need more sleep during the course of the night. On the other hand, sleep deprivation can also express itself in more subtle ways. That is, many people could be impaired as a result of daytime sleepiness, not working efficiently, not being able to remember adequately, or having memory issues, or not being able to focus or concentrate, or having lapses of attention, or not being motivated to work, or not enjoying work or play as much. All of these things are manifestations of sleep deprivation, but don't necessarily, so these types of sleep deprivation effects do not necessarily lead to this kind of profound falling asleep during the course of the day. What I'm trying to get at is that we may all have subtle degrees of impairment during the course of the day as a result of sleep deprivation, which may also be affecting our ability to function in our daily lives in critical situations. Next slide, please. So how do you assess whether sleep is enough for you? Well, obviously, the important thing is to assess, are there any cognitive or other impairments during the day? Another concept I wanted to make sure we are left with before I end today is that subtle degrees of sleep deprivation have a cumulative impact. So on the very left-hand portion of this slide is an experiment where individuals are being completely sleep deprived for 2 days. And this is the dark brown portion of the slide. You can see that after 2 whole days, the y-axis, which represents the attentional lapses, is very, very high in these people who've been deprived of sleep for 2 whole days. That is, they're making a lot of mistakes in functioning in this experiment. But notice the people who are being deprived of sleep for only 4 hours per night. Those are the light green or aqua green people on this slide. Those people are getting 4 hours of sleep per night. Now, they're not as impaired after 2 nights of doing this, but you can see that after 14 nights or 2 weeks of getting only 4 hours of sleep, they're as sleep deprived as are the people of the light brown, or the people who've not slept at all for 2 nights. So a little bit of less sleep per night over the course of many, many days or months or years can lead to very, very profound degrees of cumulative sleep deprivation. Next slide, please. Now, one way to assess whether you're too sleepy is to take this Epworth sleepiness scale. This assesses how likely you are to fall asleep, even if it's a very, very momentary nod in situations of daily living. So you may want to rate yourself as you're watching this lecture. Would you tend to doze? The scale or the key is on the bottom of the slide. 0 is never dozing. 1, slight chance of dozing. 2, moderate chance. And 3, high chance of dozing or falling asleep. Rate yourself in each of these situations on a scale of 0 to 3. Sitting and reading, watching television, sitting inactively in a public place, passenger in the car, lying down to rest in the afternoon, sitting and talking, sitting quietly, or in a car stopped at traffic. If the score is 10 or above, that implies that that person is too sleepy and really needs to get more sleep, or needs to fix some sort of problem impairing quality of sleep. Next slide, please. Timing of sleep is also critical. So many of us will, in order to make up for lost sleep at night, will stay in bed for long periods of time in the morning. So instead of, for example, getting up at 7 o'clock in the morning, we may stay in bed until 8, 9, or 10 o'clock trying to make up for lost sleep. But unfortunately, what that does is that it resets our entire circadian pacemaker, our entire sleep clock, so that the next night we may not become sleepy until 2 or 3 in the morning, because our clock now has reset itself in a 24-hour fashion. So it is critical to wake up at the same time every morning, regardless of how much sleep we've obtained during the night. And if we want to extend our sleep, the best way to do so is to go to bed earlier rather than sleeping in late during the morning hours. Increasing exposure to bright light in the morning. Again, bright light is what produces that circadian or body clock resynchronization. And it's a very important signal for the body to reset the clock. So wake up early and have your eyes exposed to bright lights, early to bed, early to rise, makes a man healthy, wealthy, and wise. Next slide, please. Now, this whole concept, this whole dictum rather, relies on the concept that light is a strong signal to the rest of the body, and this signal transcends not only to the brain but also to other body systems. And you can see how light entering the eye is inhibitory to melatonin because of its effect on the suprachiasmatic nucleus. Melatonin is the signal of light that is transmitted throughout the rest of the body. So in order to be able to transmit that light signal to the body and reset all of our body clocks, we need to make sure that we wake up at the same time every morning. And the corollary is that we need to maintain a relatively dim bedroom in the afternoon, or I'm sorry, in the evening hours, to be able to give the signal to our bodies that it's now time to go to sleep, because that's what signals melatonin to rise in our body. Next slide, please. Now, this just makes the point again, bright light during the course of the day. And, you know, there's plenty of bright light now in the environment, but we also sometimes use artificial light boxes therapeutically, as I'll mention in a couple of minutes. Next slide, please. Next slide again. There are many reasons why we tend to violate these principles. One of them, of course, is our watching television, reading in the evening hours. The evening is a time when the darkness or dim light begins to permit melatonin to rise in our bodies, therefore bringing on sleep. Well, exposure to bright light sources of, sources of bright light diminishes that melatonin level and diminishes our capacity to fall asleep and stay asleep. Next slide, please. Smartphones also, of course, are a big cause of this, and smartphones especially have a significant amount of blue light emission, and the blue spectrum of light is what creates this problem, we think, in melatonin decrease. And much of that research, interestingly, was done here at Jefferson by many scientists working in photobiology, including Dr. George Brainerd. Next slide, please. Now, one way to overcome our insatiable desire to watch television and look at our smartphones is to use these blue light blocking glasses, and they're fairly available online, many online sources, and they essentially block the blue light coming out of our iPhones and PDAs and so on. So if we have to look at our smartphones, this is one way to prevent the melatonin effects. And I would recommend wearing these lights for 2 or 3 hours prior to our normal bedtime. Next slide, please. Exercising during the day seems to enhance sleep depth. The key to exercise, though, is to do it regularly and to do it not close to bedtime, not within a few hours of bedtime. So early evening, late afternoon, or morning exercise seems to be preferred. Next slide, please. Setting aside a worry time. Many of us, in fact, most of us, probably listening into this broadcast, have high-functioning positions. There are a lot of stressors in our lives, and we tend to have worries and concerns and so on. And those concerns don't go away just because it's time to go to bed. Sometimes our minds tend to be active, processing the conflicts that we've been exposed to during the day, or even conflicts that we've been dealing with for many, many years, ever since childhood. So it's important to set aside a time where we can deal with those conflicts that is not close to bedtime. I recommend to people that I see that they spend maybe 15, 20 minutes, maybe half an hour, excuse me, after dinner or right before dinner, somewhere removed from bedtime, just either meditating or simply giving some thoughts to their lives as a way of processing some of the issues that they need to process, as opposed to waiting until bedtime when that processing begins to take place for them in a time which is not that conducive for sleep. Next slide, please. Doing something relaxing. There are many exercises that we could use: yoga, mindfulness therapies, relaxation techniques, and there are many of these available online, which I suggest that people take advantage of. Next slide, please. A warm bath. Some people benefit from a warm bath. Some people benefit from a cold bath. That's pretty idiosyncratic. But I would recommend that you explore things that make you relaxed and unwind prior to bedtime. Next slide, please. Comfortable bedroom, of course. We know that noise has a negative effect on sleep, even in the context of individuals who may not be consciously aware of that noise. So if, for example, you live next to an airport and there are airplanes flying above on a regular basis, even though you may not actually hear those airplanes at nighttime when you're in bed, experiments have shown that sleep tends to be more disruptive and less refreshing. Bedroom should be dark, obviously, to prevent melatonin increase. And the bed, there's no real magic to the bed. Whatever's comfortable, some like it hard, some like it soft, but whatever feels comfortable for you. Next slide, please. The temperature of the bedroom generally should be a little bit on the cooler side. For some reason, that tends to be sleep conducive. Next slide, please. And there are certain things which we need to avoid. For example, substances like caffeine and alcohol, heavy meals, watching the clock. I'll just mention some of these in the next few slides. Next slide, please. Caffeine, alcohol, there's no magic to caffeine. I mean, some people actually can drink caffeine close to bedtime and not have it affect their sleep. They have a liver enzyme which is very active and can metabolize it. Others do not have that enzyme and need to have their last caffeinated beverage within 12 hours of bedtime. You may want to explore what's best for you, but I, as a panacea recommendation, say to patients, don't drink caffeine after lunchtime just to be on the safe side. And of course, drinking a large, or rather having a heavy meal close to bedtime induces reflux. In general, 3 or 4 hours before bedtime, we should be minimizing fluid intake and not having anything to eat. Next slide, please. Using the bedroom for sleep, but not activities which tend to be associated with wakefulness. If you do too much in bed, which is very much like what you do in the office, well, the bedroom becomes your office. And unconsciously, those sorts of behaviors tend to trigger wakefulness types of wakefulness psychologically as well as physiologically when one is in bed. Next slide, please. So the bed should be a place only for sleep and intimate activity. And watching the clock, many people have this obsession with the time. They wake up in the middle of the night, look at the clock. I think that if people are having difficulty with sleep, they should simply turn the clock around and just forget about it until the alarm goes on the next morning. Looking at it too much tends to trigger anxiety. Next slide, please. Avoid staying in bed too long. The recommendation here is that people who have difficulty falling asleep or staying asleep, waking up and being unable to fall asleep, not stay in bed for more than 30 minutes or so, but get up out of bed, go into a different room, a dimly lit room, and then come back to bed in about half an hour when they feel sleepy. The idea is, the rationale for this is that being in bed for too long of a period of time tends to trigger frustration and anxiety, and that tends to increase the degree of sleeplessness. Next slide, please. And that simply makes that point visually. Next slide, please. Now, some of these self-help techniques may not be helpful for some of us, and what I recommend is that if they're not helpful, that one seek help. Next slide, please. When people seek help in our center, in our laboratory, we tend to study people neurophysiologically, and we have a number of variables which you look at: the electroencephalogram up top, electromyograms, EMG, breathing on the very bottom, in order to understand what might be triggering awakenings, arousals, and causing symptoms during sleep. Next slide, please. So I'll go over some of these sleep disorders with you. Let's go to the next slide. Primary insomnia is one of the most common disorders, and it's caused by stressful events, but it really occurs in the context of people who genetically, I think, and through upbringing, have a tendency to worry a great deal and to have a high degree of mental activity or spinning, mental hyperactivity, which prevents them from relaxing and going to bed. Next slide, please. One of the ways to address these concerns is cognitive behavioral therapy, or CBT. We have therapists who do this on a regular basis, and they help people through once a week, about 12 weeks or so, exercises which diminish the activation of their brains and minds and help them fall asleep. It's a very, very successful therapy and is as effective as sleep medication. Next slide, please. The biofeedback is one of the things we use during cognitive behavioral therapy to give immediate feedback into the ears of the tension level of the brain, of the forehead muscles, I should say, and this helps people understand tension and diminish tension through exercises. Next slide, please. Many of the prescriptions, many people resort to various substances as well, such as alcohol, herbals, melatonin. Unfortunately, many of these agents are not that effective for sleep, even though many of us use them. Once we see people in the context of our sleep center, next slide, please, we tend, if pharmacology is necessary, we tend to use agents which are tried and true, if you will, and those are on this slide. Naturally, we try not to use these agents for long periods of time, and the good news is that even though many of these older agents tended to have some significant side effects, the good news is that some of these newer agents, like the ones that I'm pointing to now, tend to have fewer side effects and tend to not have as many of the long-term difficulties that have been associated with sleeping pills in the past. Next slide, please. One of the things we see a lot is something called restless leg syndrome. This is characterized by an urge to move the legs, which usually begins or worsens in rest or when lying down. Sometimes people can walk around and make the urge better. And typically this is worse in the evening, and almost everybody who has this disorder complains of poor sleep and daytime sleepiness. Next slide, please. One of the ways in which this can be managed is massage techniques, sometimes hot baths or cold baths, relaxation techniques. Acupuncture also has sometimes been utilized. Next slide, please. But unfortunately, these are not that helpful in the majority of people. And again, pharmacology or medication is something we can use. These are dopamine receptor agonists on the top part of the slide, and the bottom part are the GABA receptor the alpha-2 delta ligands, such as gabapentin or rotigotine. Gabapentin and acarbol, and benzodiazepines sometimes are used. The point being that there are a number of agents that can be used to treat this syndrome, and most of these are highly effective. Next slide, please. No doubt many of you have heard of sleep apnea. It's a condition where the airway, which of course needs to be open when we breathe during sleep, is closed or closes down repetitively. And this closure is mediated by the musculature that's too lax in the upper airway and by structural abnormalities of the upper airway. Obstructive sleep apnea syndrome. Next slide, please. Obstructive apnea can produce all sorts of symptoms, such as snoring, excessive daytime sleepiness, stoppages of breathing during sleep, sometimes observed by a bed partner. Next slide, please. It can also cause significant impairments medically and health-wise, such as irritability, depression, memory impairment, high blood pressure. It can lead to heart disease, even stroke, and it can diminish lifespan. So it's a serious condition. Next slide, please. There are many ways to indicate whether or not somebody's at high risk for sleep apnea. This is only one technique called the stop bang, and people have 3 or more items positive on this slide are at higher risk of sleep apnea: snoring, feeling tired, observations of breathing stoppages, history of high blood pressure, or have a body mass index more than 35, age more than 50, large neck circumferences, or male gender. Any 3 of these or higher imply a higher risk for apnea and imply that that person should receive a formal sleep disorders consultation. Next slide, please. And there are many treatments for sleep apnea, including CPAP, continuous positive airway pressure, which puts air into the upper airway, keeping the airway open, highly effective. Next slide, please. Oral appliances can also be utilized, such as the one on the left side here, which essentially position the mandible forward and keep the throat open during sleep. We have trained, specialized dentists at Jefferson who use these techniques very, very successfully. Next slide, please. And I'm not going to go over all the treatments, but one of the more innovative recent treatments is something called upper airway stimulation therapy, where a small and tiny pacemaker takes the nerves of the upper airway and the hypoglossal nerve to expand every time there's an apnea and every time the person breathes. Excuse me. So,
Dr. Doghramji? Sorry to interrupt, but
hello.
I think your phone, do you want to try that again? We kind of lost you for a minute there.
Oh, sure. I'm sorry. Can you hear me okay now?
You sound good. Yep, I think you're fine right now. Great.
Sure. Upper airway, sorry about that. Upper airway, one of the innovative treatments at Jefferson is hypoglossal nerve stimulation or upper airway stimulation therapy, where a small pacemaker implanted in the skin paces the hypoglossal nerve in an imperceptible fashion to the patient and essentially expands the throat every time the person breathes in. A very innovative therapy of which we've done most cases right here at Jefferson. Next slide, please. And I won't go over shift work at great length, but if you could go to the next slide. Shift work is a very common problem in our society. Next slide again, please. Where shift workers, because of the rapid change in the timing of their sleep and wakefulness, begin to develop a desynchronization of the underlying sleep-wake rhythms so that they're not in sync with one another. The temperature rhythm, the cortisol rhythm, the mood rhythms, all of these various rhythms become desynchronized because people shift their sleep and wakefulness timing too rapidly for the body to adjust. And these are some of the things that we can do to help ourselves. If we are shift workers, of course, making sure that we get 8 hours of sleep, regardless of what shift we're in, and limiting the shift that we engage in to 12 hours, no more. Some people, I was lecturing to a group of emergency medical technicians the other day. They have 24 to 48 hours work shifts, which is very, very distressing because, they're driving sick people to hospitals and in some cases falling asleep and having accidents and injuring the people that they're trying to rescue. So limiting work shifts to 12 hours and no more, adhering to work shifts that make sense, that is making sure that you're on the same shift for as many days as possible. And shift workers definitely should be taking naps on a regular basis to diminish the impact of shift work. Healthy sleep habits, meaning some of the sleep hygiene techniques that we've already spoken about a bit earlier. It's very helpful for shift workers to expose their eyes to bright light during the night when they're working, if they're working overnight, and to use bright light boxes, for example, artificial light boxes, to simulate the day so that their bodies live their day cycle at nighttime. And it's also important for them to make sure that their bedrooms are as dark as possible during the day when they're asleep, and there are special blinds and shades that could do this. Avoid driving, of course, if sleepy, to avoid accidents. Caffeine is actually a good thing for shift workers if consumed judiciously to be able to help them function on the job, and regular melatonin administration may be a good idea as well. Next slide, please. And these are some of the glasses, dark glasses, that I recommend that shift workers use on the way home from work in the morning to diminish light and to get the body set for sleep mode. And the blinds that we can use in the background, you see there's a blind here which is keeping the bedroom dark. And some of the artificial light boxes which we can use when shift workers are at work. Next slide, please. And in the interest of time, I'm going to end my formal presentation at this point by thanking all of you for joining in. I went a little bit longer than I should have, for which I apologize. Hopefully I've covered a number of the self-help techniques that we can all engage in to help ourselves sleep better in the context of a non-medical situation. And of course, my suggestion is that if those self-help techniques do not work well, that people seek help. There are a number of different sleep medicine facilities in the Philadelphia area and nationally that have the physicians and the techniques to be able to diagnose some of these sleep disorders and hopefully treat them productively. Thanks again for your attention. I'd be more than happy at this point to open things up for questions.
Great, and we already have a few. So one of the first questions that came in was, is it true that some people only need 5 hours of sleep? For example, they get a headache or they feel more tired if they sleep longer than 5 hours, or have those who say that have they become more accustomed to it and don't realize that they actually may need more sleep.
Right. So we find from natural experiments that there really aren't a lot of people who can get away with more than around 7 hours or 6.5 hours of sleep. But people can get 5 hours and 5 hours only sometimes for long stretches of time, but they become sleepier and sleepier as time goes along. And we find that these people tend to fall asleep during the day or nap, sometimes unintendedly. And if they do try to get more sleep, if they're very sleep deprived, they may experience a headache because of something called REM rebound. So there's a rapid rebound of REM sleep and other sleep stages in an inappropriate fashion, which may cause some headaches and unusual sensations. So my suggestion to those people who get headaches if they sleep a little bit longer is to dose themselves incrementally so that they're getting a little bit more sleep every night, not enough to cause a headache, but enough to pay back their sleep debt gradually so that they can catch up and eventually get up to about 6.5 or 7 hours per night. Unfortunately, human beings simply cannot get away by depriving themselves of sleep for too long. Something will happen. There is a consequence to it, even if it's as subtle as a thinking abnormality, a headache, losing track of your what you're reading, losing focus, concentration. Sleep deprivation will have an impact.
Okay, great. Let's say we also have, I guess, more of a question comment about, how does poor sleep interfere with weight loss?
With weight loss?
With weight loss. So I guess if someone is trying to, lose weight, how does sleep play into that? Mm-hmm.
Absolutely. So we know from natural experiments that depriving people, normal human beings, of sleep tends to increase ghrelin and decrease leptin, and tends to favor not only eating an appetite and eating carbohydrates, but also tends to favor weight gain, even if people are having the same number of calories. It also decreases insulin sensitivity and increases amounts of glucose in the body, interestingly. So sleep deprivation basically produces almost a diabetic-like state in some people, and also favors weight gain, and also it increases the type of appetite that people have for carbohydrates and the wrong types of food. So it's the wrongest thing to do if you're trying to lose weight. The corollary is that the best thing to do if you're trying to lose weight, among other healthy things like exercise and so on, is to get a good night's sleep. It's critically important. You may find that it makes your dieting much, much easier. Next slide. I'm sorry. Next slide.
Next question. Get into the the mode. So we actually have two different people that kind of asked about the over-the-counter melatonin. So one of our alumni did ask, does over-the-counter melatonin work? And also someone asked if what are the negative effects that you see of taking that melatonin regularly, especially when some people have to continually increase dosage to see the same effects. So if you just want to cover melatonin over the counter.
No problems. Yeah, the data show that in insomniacs, people who cannot sleep, fall asleep, or stay asleep, that melatonin administration tends to have a very, very slight, modest, but positive effect in helping them fall asleep and stay asleep. So it may not be a bad choice of medication. But here's the problem. Melatonin preparations, over-the-counter preparations, are not regulated by the FDA. And there's no quality control, if you will, which tells us that melatonin, and that particular brand of melatonin, is made well, is pure, and does not have any contaminants and so on and so forth. So that is one of the critical problems with melatonin. So I would say if you are taking melatonin, if it's not working, you might want to switch brands and maybe switch brands again. That's number one. Number two, the other problem with melatonin is that melatonin has not one but two effects on sleep. Number one, it has the effect which we all think it has, which is it makes us sleepy and may help sleep. But the second effect is one which we don't think about very much, and that is the fact that it adjusts our body clocks. And it does so based critically on the time that we take it. So you can take melatonin at the wrong time, and it can actually make you sleep worse than if you take it at the right time. That is after taking the exact same dose. So the problem is that the science of sleep medicine has not developed to the point where we can, in a practical way, tell each individual what's the best time to take melatonin for that individual. It's kind of a guessing game. So if you're trying to help yourself fall asleep and you're a garden variety insomniac, taking melatonin close to bedtime is probably the right thing to do. But if you have something called delayed sleep phase syndrome, where your whole body clock is shifted in the wrong direction, you have insomnia, but it's because your body clock is now deranged. Or if you're a shift worker, or if you have another kind of circadian rhythm abnormality, taking melatonin at bedtime can actually be destructive. So the problem with melatonin is that it's kind of a guessing game as to when to take it and how much to take. So I would say experiment with it. If it doesn't work for you, and especially if it makes matters worse, stop taking it. Can it be bad for you? Well, the data show that in laboratory animals, it has the effect of diminishing spermatogenesis or gonadal tissue formation, and we think that it may also alter the receptiveness, or rather the sensitivity of some receptors in the body to medications and even chemotherapeutic agents. So I would say that people who take melatonin can do so, maybe in short spurts, maybe a month or two, maybe a few weeks. But I certainly would not recommend that people take it for long periods of time, especially if they're younger individuals or older people who are on the multiple medications.
Great. So let's see here. We have a few. This one's great. So what can someone do to get better sleep if their partner snores other than separate bedrooms?
Yeah. Well, I guess the right thing to do there, I mean, you could use earplugs and so on, but the right thing to do there is to suggest that the partner maybe get an evaluation in the sleep center or in otolaryngologist, or maybe go to the family physician asking for advice or referral, because the snoring could represent sleep apnea, in which case it's not benign and it's more than just an annoyance to the bed partner. But if it's simple snoring, there are a lot of things that could be done to get rid of snoring, such as small devices that go inside the mouth or small dilators that go on top of the nose. Those are commercially available. Dentists also can help in that regard. So I would say the best thing to do is to get the partner to get evaluated and get the snoring stopped. On the other hand, if your bed partner doesn't want to go anywhere, doesn't want to get evaluated, thinks that this is your problem and not theirs, and why should they bother? Well, in that case, I think you're stuck. Either leave the bedroom or you have to resort to earplugs, and there are many earplugs that are available these days, which are pretty effective.
Great. So here's a great question. Any recommendations on how to handle all the data that patients bring in from sleep devices that they're buying on the internet and wearing at home?
Yeah, that's a great question. So I actually looked into this area a number of a number of months ago. There's a nice paper on it that you could Google and get at. I think it was in the Journal of Clinical Sleep Medicine, looking at the commercially available devices and what was the science behind the claims that many of them make in terms of being able to assess sleep depth and being able to produce these charts or normograms of deep sleep and light sleep and so on and so forth. The bad news is that most of these have either not been validated against polysomnography or sleep study or standard sleep studies, or if they claim to be validated, they do not make their data available to us and independent parties for analysis so that we can substantiate their validation techniques. So at this point, the data are not, the validity of the data is unclear. I would say, though, that if a person comes to me and says, look, I'm getting so much deep sleep and so much light sleep, I kind of I don't discourage that kind of attention to sleep. In fact, I encourage them. I kind of tell them that we don't know about the meaning of a lot of this, but that I really applaud the fact that they are looking at their sleep and that they're trying their best to get better sleep because they're convinced that better sleep might be better. And even I tell them that we just don't have a lot of data on what they're looking at, that yeah, if they try to improve sleep and it makes them feel better the next day, that's got to be a good thing. There are many devices also that exist or being manufactured or will be manufactured, which also have therapeutic angles to them. So they not only monitor sleep, but also seem to at least that they at least claim that they can help improve sleep by providing music or relaxation techniques and so on. And I think those are probably good things because they force individuals to engage in mindfulness therapies or relaxation therapies, which have got to be good for sleep. So on the whole, I think this is a good thing. But at this point, I think there are not a lot of data to guide us scientifically to make concrete advice to patients based on the data that they bring to us.
Great. We have a bunch more questions, so hopefully we can stay on the line for a little bit longer because I think this is a great topic that everyone has a lot of questions for. So here's a question. Can you, I guess, address issues like narcolepsy and sleep paralysis, and are there any natural ways to manage these issues?
Mm-hmm. Yeah, so you might want to look up a book on sleep paralysis that I co-wrote with Dr. Sharpless. It's the definitive textbook on it. It's short, it's readable, and it's a condition, it's a phenomenon where people feel paralyzed in their sleep, and it's usually associated with vivid dreaming, where people dream that especially usually about a threatening something threatening about to happen to them, like somebody walking up the stairs with a knife and so on, or somebody staring at them while they're lying immobile in bed, unable to move. Sleep paralysis, hypnagogic hallucination, and these are phenomena which happen a great deal in narcoleptics. Narcoleptics also have something called cataplexy, often where they lose control of their body muscles after a laughter or anger or an emotional feeling or experience. So after laughing, they may collapse or lose control of a body part, fingers, so on. Narcolepsy also causes significant daytime sleepiness to the point that people may not be able to function adequately. So those are the four major symptoms of narcolepsy. Narcolepsy is best diagnosed in a sleep laboratory. There's certain laboratory EEG brainwave changes which we see during daytime multiple nap testing. And there are many treatments. We use stimulants to treat sleepiness during the day, certain types of antidepressants to diminish cataplexy, and then there are a number of medications, one of them called gamma hydroxybutyrate or Xyrem, which can be used at nighttime to improve sleepiness during the day. There are two drugs that will be introduced in the near future, one called Wakix and the other called JZP-110, which will be available for the treatment of narcolepsy. Very exciting and stronger medications with fewer side effects. So narcolepsy is a condition which is eminently treatable. It's diagnosable and treatable, and is something which occurs mainly in younger individuals, but can also strike in middle age.
Great. And then can you just repeat the title of the book on sleep paralysis again?
Sure. It's called Sleep Paralysis, and it's by myself and Brian Sharpless, Sharpless.
Great. Thank you. All right. So let's see here. In addition to what was shared, are there any additional recommendations for reestablishing a healthy sleep hygiene with a newborn in the home?
Oh, my goodness. Well, yeah, newborns, of course, have a sleep cycle that's not well formed yet, so they tend to spend a lot of time napping during the day, but unfortunately, they also don't have a solid sleep segment during the night, so they'll wake and sleep all night. It takes about 3, 4, 5, 6 months for that bimodal sleep cycle to set in, so that they sleep a solid night and then maybe nap only at certain times during the day, such as the afternoon. So the best thing to do, if you're a caretaker, a caregiver, during that period of time, is to sleep whenever you can. I mean, when they're sleeping, you should be asleep, and during the day, you should probably take a couple of naps because you're not going to sleep well at night. But I think that unfortunately, it's not a normal time when it comes to our body's sleep and wakefulness. It is an insult to our sleep and wakefulness. And do the best you can. And remember, it'll only be another few months before you can start getting a good night's sleep.
Great. Does teeth grinding have an effect on the sleep architecture quality?
It seems to. People of bruxism or tooth grinding seem to have repetitive arousals or awakenings in conjunction with the tooth grinding episodes, and they're not necessarily aware consciously of those awakenings. But the awakenings or arousals are short enough and subtle enough that they may not be aware of them. But nevertheless, especially if tooth grinding is frequent, those arousals could be frequent also, and therefore can cause a poor sleep and therefore lead to daytime sleepiness. And that sleepiness could become greater and greater as the days progress. So I would say if you do have tooth grinding and you're feeling run down during the course of the day, you might want to get some help. Many dentists have devices which can be used for tooth grinding. We also can use certain medications to diminish the impact and eliminate tooth grinding altogether at times, actually, so that people can sleep through it. There are also some psychological treatments like behavioral therapy, relaxation techniques, which can be very helpful for tooth grinding as well.
Great. Now, does constant white noise affect sleep negatively, as opposed to noises from something like a nearby airport?
Yeah, so the people who benefit from white noise are those people who are too in tune to random noises in the environment. So if you're lying in bed, your mind is sort of going a mile a minute. You're maybe not too relaxed at that point. And there's a drippy faucet. Your mind begins to focus on that drippy faucet and or random noises from the street, and you're sort of waiting for the next truck to go by or the next airplane to fly by, and you're anticipating it. The anticipatory anxiety increases. So a white noise can wipe out that background random noise, if you will, and diminish your anticipation of noises in the environment. So it decreases anxiety. Now, true, white noise itself can impact sleep negatively to some extent as well, because you're going to be a bit aroused from that white noise. But the net effect is a positive one, because you're at least able to fall asleep and not focus on the environment in this highly anxious state. So I would say these white noise generators are helpful for that kind of anxious person during sleep, even though they may introduce a little bit of a sleep disruption after people do fall asleep.
Great. Let's see here. To change sleep rhythm, should you gradually change wake time, or is it better to just change the wake time at once?
No, it's always better to do it gradually, especially if your delay in waking is 3 or 4 hours, apart from when you want to get up. So if you want to get up at 7 o'clock in the morning and you're naturally getting up out of bed or waking at noon, it's best to get yourself to 7 a.m. gradually by increments of something along the lines of half an hour per day. So wake up a half hour earlier tomorrow, the day after half an hour earlier, the day after half an hour even earlier. And as soon as you get up, get plenty of light outdoors. Now, it doesn't much matter what time you go to bed the next night. Your body should catch up and begin to feel sleepy in the evening, especially if you're using those glasses that prevent blue light and making the environment somewhat dim. But yes, easy does it, slowly does it.
Great. You mentioned cooler temperatures at night. What do you consider cooler?
Yeah, that's a good question. Nobody's looked at that carefully, but around 70 degrees or so is considered to be not normal or average. I would say set your thermometer, or thermostat rather, to something like 68 or 66 degrees. That's the sweet spot, it seems, for most people.
Great. Going back, we had another melatonin question. Do you recommend melatonin for use in pediatric patients?
Yeah, not a bad idea. Again, as long as it's not done too long because of the effects on gonadogenesis and other areas. But yeah, youngsters who have insomnia, who have anxiety-related insomnia, or even whatever the cause might be, if we can't find a specific treatment for the problem they're having, i.e., a physiologic problem which is treated with a specific medication, and so on and so forth, then if we're going to treat the insomnia symptomatically directly, we don't want to use a sleeping pill. We don't want to use benzodiazepines, which in youngsters the danger is that they may foment or increase the predilection for use of those agents in later life. Although it's never been shown, it's certainly a possibility. So, yeah, melatonin may not be a bad idea in pediatric population, people, kids between the age of 5, 6, 7, whatever, maybe 12 or 13, 1, 2, or 3 milligrams at bedtime usually is what does the trick.
Okay, great. So let's see, I'm just trying to go through a few of them. So what happens, what if you sleep from 10 p.m. to 6 a.m., you get your full recommended hours and you wake up and you just don't feel rested? Ms. Alum also had the same double question about maybe drinking some tea before bed, like the sleepy time tea. Is it healthy to drink that sort of thing regularly? But thoughts on those two questions.
So, sure, thank you. If you're waking up not feeling rested after 8 hours of sleep, then it could mean that you have not gotten enough sleep in the past, few weeks or months, that you're still making up for that. Right? Your body's waking up and in the morning and saying, just a second, I need more. So if you've been getting 5 or 6 hours and now all of a sudden you get 8 and you wake up feeling unrefreshed, well, you may need to get 8 hours or 9 hours regularly for the next few weeks and catch up. Now, if you're already doing that, if you've been getting 8 hours of sleep regularly or 9 hours, whatever is regularly, and for weeks and weeks, and you're still waking up feeling unrefreshed, then there could be a couple of things wrong. There may be something happening during your sleep that's causing the quality of your sleep to be impaired. You may not be conscious of it, but that may be happening. And in that case, the only way in which you can really address that is to go to a sleep person and get sleep tested or have them look into that in a bit greater detail. It could also be that you're a long sleeper, that you are genetically programmed to need more sleep, and there are such people. Just like there are these few people who are short sleepers, there may be some people who are long sleepers and they need 10 or 12 hours of sleep. Thankfully, there aren't that many people, and again, that's something which may require testing. In terms of the sleepy time teas and so on, those are for people who have problems getting to sleep or falling asleep, not for people who are getting 8 hours of sleep and waking up feeling tired. Those teas tend to produce a bit of sedation, which may make people sleep a bit better. So they've not been proven to work, and their active agents have not been well defined. So some of them have, some I think have melatonin, others have like hops or various grains or wheat, and so on and so forth. I would say that if you have insomnia, can't sleep, and you try some of these teas and they work for you, who can quarrel with success? They're probably not dangerous, but they're probably not going to be that helpful if you're getting a good night's sleep, 8 hours of sleep, but waking up feeling tired.
Great. There are CBTI programs on the web. Are these useful? I'm not quite sure what that is.
Yeah, the ones that are, I'm sorry, can you hear me okay?
Yes, yep, you're fine.
Yeah, thank you. Yeah, the ones that seem to be helpful, the one that's actually been looked at the most is something called SHUT-I, SHUT-I. That's a program which has a lot of data backing it up. It's been validated a number of times. The problem is that it's maybe not a problem, but it does require some payment, some form of payment to be able to use that. And the data are fairly impressive. It seems to work just as great as person-to-person, in-person, human being to human being CBT. So I would say that the answer is yes. Now, there's an app which I also often recommend for patients called CBTI Coach. And I think, let me just make sure I have the spelling correct. It's, there we go. I think I can find it on my iPhone. There we go, CBT-I Coach. And it's not CBT in the true sense of the word, but it has a lot of the recommendations and principles, sleep hygiene principles, sleep logs, meditation techniques, and so on, that the other 4 pay CBT programs have. So I would say that that's a nice free app that's good to start with for many patients or many people who are having problems. And if that does not work, then you can progress to the other more expensive programs.
Great. And then I guess just 1 or 2 more questions. One of our alumni, she has a terrible time falling asleep, and many times she feels a jerk in her chest, or it could be he, I'm sorry, or jerk awake just when they fall asleep. And then they're awake for a long time. What is this, and how can it be addressed?
Yeah, so that's a common phenomenon, the part where you wake up suddenly after just falling asleep. It's called a hypnic jerk or hypnic myoclonus. And it's common in a lot of people who, especially if they're a bit sleep deprived, they tend to enter sleep quickly, and the body sort of wakes them up and makes them go back into sleep in a more orderly fashion. So if it's happening a lot, then it may mean that there's something else going on physiologically in the body that needs to be evaluated. I would say that would be a good example of a person who may need a formal sleep study, so that we can understand what exactly is it that's waking that person up. Again, a hypnic jerk here and there every once in a while, once every few weeks, is very common and normal. But if something like this is happening nightly and multiple times per night, then it really has to be evaluated.
Right. So I think we have time for 1 more question, and there's a few that are coming in with the same theme, kind of talking about, being able to fall asleep, but waking up in 3 hours. What are some of, apps or different things that you can do to get back to sleep? Someone mentioned, the counting backwards, counting sheep.
Yeah.
Or, some sort of like meditation or relaxation in the bed. I know you mentioned getting up, after 30 minutes if you can't fall back asleep. But what are some things that people can try to maybe help themselves get back to sleep?
No, I think that you said it, Rebecca, the person, getting up out of bed, spending some time in a different room, have your yellow, bright blue light blocking glasses, on your eyes so that you're not getting a lot of bright light in. So try to minimize your time in bed trying to fall asleep, and just keep that up for a while. Some self-help meditation techniques, these are available on the 2 apps that I mentioned, or the 1 app that I mentioned. So mindfulness therapy, being able to relax your mind and being able to get back to sleep. So those types of things are very helpful and should be practiced repetitively to be able for them to work. So yeah, give it a try. I think those 2 things are very helpful for a lot of people.
All right, great. Thank you so much. For those of you that didn't have a chance to have your questions answered, we will compile them and send them to Dr. Doghramji after the presentation. Again, this presentation has been recorded, so we will send it out to everyone who was able to attend, so you can rewatch it, share it. It will also be on our alumni YouTube channel. But Louise and I just want to thank everyone for signing on, and thank you so much, Dr. Doghramji, for coming on this evening. I think there's a lot of interest in this, and it might be something that we might want to do another time, because I think people have a lot of questions, and we all feel we need more sleep all the time.
Oh, it's been a pleasure. Thank you for having me.
Yeah, thank you. Thank you
all.
Thank you. Have a wonderful night.